Assalamu alaikum warahmatullah. The topic we will be discussing today, the people who are appearing in the exam, the Viva. It will be a relatively new topic, not familiar to everyone. Though it's very there is nothing out of the world in this topic, but uh, maybe if it is asked suddenly, you don't have any ideas what is opioid-free anesthesia. Okay, so in next few minutes, I will be giving you some idea. Okay. Uh, if I ask you what are the basic components of anesthesia, so can anyone tell what, like, if you want to give a good anesthesia, what do you mean by good anesthesia? Please, anyone? Sundas, Rabia, no one wants to speak out. So actually, our purpose is uh, to have. I will tell you the components. Analgesia is one of the component. Amnesia, patient does not remember anything. Then hypnosis or patient sleeping. Okay. Then another component which is required is muscle relaxation and like anxiolysis. I'm sorry, anxiolysis. Okay. And then you can say stress response management. Okay. So like these are basic component of a good anesthesia. Of course, there will be some other things related to it, like to monitor these things, that will be with the form of monitoring. Okay, so there should be some good fluid management, but like maybe basically this is what is called as good anesthesia. Okay, so now if we just think that uh, the things which is very important, one of the important component is pain, like analgesia, as I told you, that what are different mechanism to control pain. Okay, so that will be transduction. Okay, transduction, transmission, modulation, and perception. So whatever we are doing, we have to control the pain pathway in the form in four steps. Usually, I had discussed this topic in detail with the basic concept for pain management. This will be one component of this our discussion today. That we need the pain pathway to be stopped. Okay, so if, for example, if we want to have a good anesthesia and good analgesia, we should be thinking in that way, that how we can control the stimulus from where it is generating. So this is one thing. Then, like what, as I have to tell you about opioids. So what is the opioid? What is the role of opioids here? Opioid does not affect transduction. It does not affect much of the transmission. It has effect on modulation and perception. Okay. So modulation and perception, the result whenever patient is feeling pain, the result is in the form of sympathetic stimulus. Okay. Sympathetic stimulus. And like with the help of modulation and some effect on perception, they are actually have some effects on the sympathetic response to the pain, that is in the form of a increase in change in heart rate, blood pressure. So that is what is if being affected by opioids without much change in cardiac output, and much without not much having cardiac depressant effect. Okay, so if we just have a look on the opioids which we are using, the thing is that the basic purpose, unfortunately, is the inflammatory response, because whenever there is pain, there is inflammation. Okay, so the opioids have no anti-inflammatory effect. For anti-inflammatory effect, you need to have NSAIDs, you need to have and steroids. Okay, you need of course, it will not have direct effect, but paracetamol, not much effect on inflammation, but it just modify the response to inflammation by having effect on perception. Okay, so these are the medications which we should be using. And then to have effect on transduction, we should be using local anesthetics to whatever place the NCN is going to be given. If we just make our routine to give local anesthesia, local infiltration, unfortunately, if we will be offering this to surgeon, because not all anesthetists are doing it, so unfortunately the surgeons they don't care. They are not interested. They're not concerned about what is happening when they touch the patient with their knife. They are not interested. So we have to make them learn. So the ways we can do it, whenever we are giving any block, any regional anesthesia block, we are giving, for example, any compartment block, tab block, or erector spiny block, or this PAX 1, PAX 2 block, or any block, femoral nerve block. You can name any block which we are giving before the NCN. Actually, we are controlling the pain pathway. We are blunting what you say, nip the evil in the bud. Okay. So if you want to give a good anesthesia, this is what you want. And again, I will bring out in opioid has nothing to do with it. Opioid will only change the response to the pain, but they are not doing anything on the pain pathway. Okay, so actually these are the things which are more important. You can use them anyways. You can, if you want to give a good anesthesia, you can use these medications anyways. So what's the use of opioids? So this is one thing. So the concept is preemptive analgesia. So spread this message. Try to give paracetamol, okay, and this one and NSAID, okay, local infiltration, okay, and there is one medication which is this can be given in oral form as well, way below before maybe 1 hour, 2 hours before surgery, so that the response has already been achieved. But still, at least you try to give it before the NCN is being given. So try to make it a habit. Local infiltration before they give the NCN. This will be a very important thing to get a good response to the pain. Okay, so this is what you should be doing. Uh, Before that, if we just now someone will be asking, we are using opioids to blunt the stress response of intubation. Okay, if you are doing any surgery in which you are giving general anesthesia with the hand, so now again there are alternatives to it. Again, if you are using some, all of us use lidocaine. Majority people, either in the form of spray or in the form of IV. Okay, so if we use it properly, then this response will be blunted. Then other medication which is highly recommended is dexmedetomidine. Okay, if you start, there is a big debate on how much dose you should be giving. This is a big debate, that how much dexmedetomidine you should be giving, because this will be variable in very different patients, different patient population, and even the dose which is written that 1 microgram per kg over certain period, 15 minutes or 10 minutes, whatever. Actually, this can create a lot of problem. It can cause significant bradycardia. Okay, it can cause hypotension. Okay, so the better way is that you don't give this dose in every patient. You just start, maybe you can start in an infusion and titrate according to the response. Like, for example, if you want the heart rate to be in the range between 60 to 80, for example, but you don't want below or up, so you can titrate in a dose that will be giving you the results. Why to give it too much? Because if you give too much dexmedetomidine, not only there will be bradycardia and hypotension, if you are using it in a shorter procedure, maybe you will have delayed recovery, delayed consciousness, not without delayed consciousness, without respiratory depression, without respiratory depression. The patient will be breathing very nicely, but patient will not be opening the eyes. Okay, so this will be the problem if you are using slightly higher dose. So this is the problem. Then another thing, people always be afraid of using ketamine. They are afraid that ketamine will cause tachycardia and blood pressure and pulmonary artery pressure and systemic vascular resistance. There are so many bad things which are told about ketamine. Actually, if you are using in a small dose, maybe 0.25 to zero point 0.5 milligram per kg, okay, even you again, you can use the minimum possible dose. Like what I use is 20 to 25 milligram in an adult. Okay. So it gives a very good result. So if you are using 20 to 25 milligram of ketamine at the time of induction, this will be giving you a very good result even in the blunting the stress response of intubation. It has very good analgesic effect. Okay. And by the time after intubation, the patient will be receiving the surgical stimulus. Again, it will be of great help. So if you want to blunt this response, dexmedetomidine is a very good choice. Yes, of course, people will be saying that you can use opioids as well, but of course, opioids, we are just trying to find alternative of opioids because opioids have just have so many problems. I will just come to, first of all, we are trying that what are the alternatives, then I will tell you what are the problems which are not there in, because still if you have used dexmedetomidine, there will be no respiratory depression. Okay, so there will be no problems like we face if we have given, because if for example the surgeries in which it will be helping opioid for anesthesia, one of them will be obese patients. Okay, bariatric surgery. So yes, it still patient can have obstruction. Remember this word, obstruction, because of tongue falling. No medication has nothing to do with this one. But central respiratory depression or respiratory depression out of context of this physical obstruction will not be there if you are using dexmedetomidine. So overall, personally speaking, as I told you that I don't use opioids at all in majority of surgeries these days, and I have control, because maybe few seconds, you will have few seconds to control everything, so you can titrate the dose of Presidex and you will get the result in a much better way and in a much sustained way. Because usually what you, if you are using, for example, fentanyl, okay, people are using, for example, 100 mics of fentanyl before induction, okay, and then they are getting the result for intubation. Still, I can guarantee you that still there will be 10 to 20% change in the heart rate or blood pressure. Okay, so once they have given it, then what happens again what happens that when the NCN is being given, again they need to do something, because fentanyl effect will not last for more than 15 to 20 minutes, unfortunately, because fentanyl is highly lipid soluble and it does not remain in the circulation. If, for example, you want to use any medication which will cover the response to pain on the surgical stimulus as well, that is our grandfather morphine, the grandfather of opioids. But it is not freely available, at least at least in majority of countries it's not freely available to every hospital. Like I know that I never use morphine during my training. It was not available. It was only available in specific operation theaters, like cardiac operation theaters, because there was no other replacement because of misuse of morphine. Okay, so opioid, this is the first problem. Opioid, why we should not use opioid? There, it is an addictive medication. So there is a chance of patient having addiction. I tell you something. There are so many incidents of anesthetists abusing it. At least in my experience, at least I know two people who were with me, working with me, and they one of them was kicked out of the hospital and one of them actually destroyed her life, and actually she died at in a very young age. So this I can tell you a personal sort of experience, that it is a terrible medication. And another, this is one thing. Another thing, I will tell you again my personal experience, that once I was bitten by scorpion, and it was the worst pain of my life. And when I received, it was not a very powerful opioid, it was actually nalbuphine, which is in category, it's an opioid agonist antagonist. It's not, it's a mixed sort of thing. Okay. So I will tell you personally that I was having pain, but I was not feeling it. And rather I had, literally I can tell you, it happened around 10 years ago, and I had euphoria. I started laughing. So that day I realized one thing, that how much addicts enjoy their life, because they they don't care about anything after they receive opiates. After they take opiates, I had euphoria. I started laughing. I still can recall what has happened to me. It was my first experience with opiates. So still I cannot forget it. So yes, it will give you a very sense of pleasure. Okay, it will give you a sense of pleasure and satisfaction, which actually is not the purpose in surgery. We don't want to please the patient. We want to control the pain in a way that it is sustainable. So you can say that yes, we are using opioids. Everyone is using opioids, but actually opioids are not a good medication for pain relief. This is my point of view, and point of view of many people in the world. That's why they are trying to delete opioid from their use. When I was searching this thing, I just found there is a society of opioid free anesthesia, who are trying to spread their message with the alternative medication. So this is one of the thing. The other, I will just chalk out the other problems. Big problem, post operative nausea, vomiting. Okay. This is, yes, of course, other factors will be important. So if you want to have a very good post operative course, whenever I tell you something, whenever possible, whenever available, of course it will not be available everywhere, but whenever available, you use the rocuronium combined with sugammadex. You don't need to use neostigmine. This will be a big factor for prevention of post operative nausea and vomiting. Okay. Then you minimize the use of inhalational agents, and use inhalational agents which does not have active metabolite too much. Okay. Not, sorry, not active metabolite, who does not undergo a lot of metabolism. So for that, desflurane is the best choice. Of course it's not available in everywhere, but the next number will be sevoflurane versus isoflurane. So you will be surprised. The sevoflurane has 2% metabolism, and isoflurane has less metabolism than. So if you remember the rule of 20, rule of 2, so 2% for sevo, 0.2% for iso, 0.02% for desflurane. You can say 0.05, less than 0.05. So, and the big one is halothane, 20%. Okay. So wow, of course it's not available, like not used much, but so this is not non only factor, but it is one of the biggest factor, and actually the most common of medications which are being used in all majority of hospitals. For example, tramadol, terrible post-operative nausea vomiting. Pethidine, terrible post-operative nausea vomiting. Morphine, of course, it will cause nausea vomiting. So these are the available, and of course nalbuphine. Nalbuphine may be a little less, I think, but still, I think these are the medications which are being used by a majority of people to treat postoperative pain. Pethidine. Some words about pethidine. If you Google which opioid has been associated with which opioid is being associated with unwanted cardiovascular effects, okay, you will be surprised that it is pethidine, because it causes tachycardia. Okay. So the purpose of relieving pain, purpose of relieving the stress response, what are you getting? And pethidine, in even in the hospital where I am working now, pethidine is being used like Ruh Afza of Pakistan or Gawa of Saudi Arabia. Pethidine is being used like anything, because what will happen? It will calm down the patient, it will relax the patient, and pethidine is the most favorite medication for the nurses. because they don't want the patient to be irritable and fighting or aggressive or saying anything. So they give pethidine and they are very happy. Other medication, tramadol, they use it. Pethidine is also being used for shivering and everything, but actually, practically speaking, you are just trying to snub the symptoms. It has no effect on the pain pathway actually. So if you are not using the other medications which are better than these one, and you are trying to control the pain, actually it's not serving the purpose. Again, tramadol has also causes tachycardia, and especially if the patients are taking any antidepressants. Okay, antidepressants and even antipsychotic medicine, too much, not much, but antidepressants, because it increases the catecholamines. Okay, so it has tramadol is not a good choice in such patients. So a postoperative nausea vomiting, these unwanted effects, then especially with reference to patients having colorectal surgery. So ileus is a big problem. If you ask a general surgeon who is doing an laparoscopic, any GI surgery, ileus is a terrible thing. Ileus will cause what? Stretch. Okay. So, by the way, after visceral, after this abdominal surgery, the pain is not because of the cut, it is because of the stretch. So, ileus will cause distension. So, what will happen? There will be pain. And what will they do? Mashallah. They are adding in fuel to the injury. They are giving more opioids. My patient is having pain. So, it is causing more ileus. So, what are you doing? It's not a good choice at all in these patients. Okay. So this is a big problem with reference to postoperative ileus. Okay. So then another problem and what will happen if you have postoperative nausea vomiting? Just recall the discharge criteria from day surgery. The patient discharge can be delayed. Okay. Then if the patient is retching, patient is vomiting, trying to vomit, especially with abdominal surgery. I again repeat, especially in abdominal surgery, it will create big problem with the any anastomosis being done. It will be having problem with the wound. It can be there for any wound, but with the abdominal wound, it will be a big problem. So again, this is a single most point for which opioid-free anesthesia will be a very good solution. Then ERAS, enhanced recovery after surgery. ERAS protocol also will create a problem. If you are having this ERAS protocol, you are trying to enhance recovery after surgery. You are trying to reduce the morbidity. You want to reduce the hospital stay, and you are giving a lot of opioids. So it will create problem for you. Okay. So this is again a problem you can avoid if you are not giving opioids. Then respiratory depression. Okay, respiratory depression. So especially the combo you are using in majority of patients, we are giving midazolam. Okay, and we are giving fentanyl, and then there is pain, and we give morphine. Okay, so now a combination which will have synergistic effect on respiratory center. It will decrease the response of CO2 on O2 to respiratory center. Okay. So, what is the meaning of synergistic effect? That it is not 1 plus 1 is equal to 2. It will be 1 plus 1 is more than 2. It may be 3. It may be 4. Okay. So, this will be a problem if you are using it in, again, obese patients and any patient having like any OSA or things like that. So this will be the problem. And for example, in any patient in which CO2 retention will be a problem. So this will not be a good choice. So respiratory depression is there with almost all the opioids. So people don't give morphine. People are afraid of giving morphine. They are giving pethidine. So actually, there is not much of the difference in respiratory depression uh, caused by pethidine or morphine. Okay, I think pethidine can also cause respiratory depression. It is also mu receptor agonist like morphine. So you should be just thinking about it and you will come to know that this is a problem you should be catering. Then another problem is hyperalgesia. Okay, opioid induced hyperalgesia. So there is a role of ketamine. Okay, you can read the text about it, that ketamine has very good effect in counteracting opioid induced hyperalgesia. It has effect on NMDA receptors in the thalamus. Okay, and it is a good way to control hyperalgesia. The most culprit medication which is documented for opioid induced hyperalgesia is remifentanil actually. Okay, but you will see that sometimes if you are using a lot of opioids in patients, then maybe the requirement will be further increased. Even sometime it will be developed in a long tolerance will be developed by repeated use in a over a long time, but sometime tachyphylaxis can also occur. Okay, so tachyphylaxis versus tolerance. So you should be knowing the concept about tolerance and tachyphylaxis. So tachyphylaxis will be developed in a short period of time, while tolerance will take some more time. Okay. So again, this is a problem because with remifentanil, actually, I have myself faced terrible hyperalgesia, keep making the blood pressure like crazy blood pressure. I was giving I had no don't have much experience of remifentanil. I was assistant consultant at King Faisal. I stopped remifentanil and I had given morphine. So, but I did not appreciate that morphine will take 15 minutes. And maybe that morphine was not enough for that patient. I had given relatively smaller dose of morphine and I had given not in enough time. Like I stopped and I gave. So what happened? The remifentanil was washed out in the blood and suddenly blood pressure went up to 200 and it was crazy stuff. So yes, if you want to do is that like that, you have to give some medication which will have immediate effect. So if you want to use it, either you stop it, you should give at least 15 minutes before you give morphine in a adequate dose, or you can give both fentanyl and morphine because fentanyl effect will come immediately and then it will be continued with morphine. Okay, so this will be the way to control this problem. or or the better problem will be that you use other medications simultaneously. You should be giving paracetamol and a small dose of ketamine and a small dose of alternative medications, so this will be helping you. Okay, so these are the major problem with reference to opioids use. Okay, let me show you. I just opened this. I was just reading from this article. Because tomorrow and day after tomorrow we will be discussing some of the medications as an alternative. So today I was just trying to give you a concept. What are the basic concept of why to use opioid free anesthesia or why to use opioid sparing anesthesia. Okay, so one medication I did not mention, gabapentin. It is also being used preemptively, like gabapentin or pregabalin is being used preoperatively as a part of ERAS protocol. Okay, they are giving it even in arthroscopies before surgery, and it is leading to like very good pain relief and have opioid sparing effect. Okay, don't require much of opioids. Then another thing, as I was telling you, that dexmedetomidine will have very good effect with anxiolysis as well. Like you want to give midazolam, and actually when you are using this dexmedetomidine in a wise way, you can give even intranasal uh, press this dexmedetomidine, and it will cause very good anxiolysis and sedation. Okay, I'm yet to see what is the comparable effect with the amnesia created by midazolam. This is I have to see, I have to read about it. Practically speaking, in my opinion, there is no need for, because since many months I have stopped using midazolam. When I'm using dexmedetomidine, I did not find any reason to give even midazolam. So my patients are very comfortable in postoperative period. They are not like I have even achieved good postoperative outcome in patients undergoing this one nasal surgeries, which are one of the culprit for postoperative delirium, because these patients who undergo DNS surgery or rhinoplasty, actually, because when they wake up their nose are closed, and they are young aggressive people sometimes, so usually they are very aggressive, and most of people will appreciate that these patients, because their nose is closed, and now you are in a big trouble, because if they clench the teeth, actually even it's a problem for you. So even mask ventilation will become a problem for you. This will be immediate period, and if you have given opioids, actually it creates more problem with the respiratory depression. They are following the tongue, and now you are not able to do much of the things. Because airway is not the solution. Airway is not the solution, that you keep the airway there all the time. Because yes, we tell everyone that you have to use airway, but practically airway, a patient will not tolerate airway. He will pull out the airway, throw it, and again after next moment, if you have given more opioid, the patient is sleeping and tongue is falling, and again the same problem is occurring. So I'm telling you the practical aspect. The practically it is very difficult to handle these patients. Okay, so with the use of this like opioid free, the concept of opioid free anesthesia is because there is, in US, I was just reading, you just have a look here, what they have written here. The modern opioids epidemic was born as a consequence in 2012. The number of deaths related to prescription opioid use surpassed the number of deaths from suicide and motor vehicle accident. This is data from US, of course. Okay, so I'm telling you that we just don't think about it, because of course uh, uh, we will not misuse it. Though that's why we will in Saudi Arabia there is so much strict rule that you have to document everything, how much opioid you have used, and you don't know maybe that people are observing you, that how much you give. Even in our hospital, it's totally controlled by they are preparing the medication, you are signing, they are taking. So it's a big bothersome thing. So I think I will stop here today. Okay. And in our preceding, like coming discussions will be with reference to what will be the role of magnesium, what will be the role of ketamine, what will be the role of lidocaine. Okay. So inshallah, and even gabapentin. So I have given you a concept. What is the world of opioid free anesthesia? What advantages you can get? What are the problems which we can face with the use of opioids? Okay. So I will stop here. Any comments or any question or anything? Okay. So we will continue our discussion tomorrow, inshallah, from where we are leaving today. Okay. Bye bye. Thank you very much, all of you, for joining.